Hello everyone, now let us discuss about pharmacology of anti-rheumatoid drugs. So let us first discuss about inflammatory response. The inflammatory response occurs in tissues following an injury or exposure to pathogen or other noxious substances. It can be of two types. Innate, which is also called as non-adaptive response, and second is adaptive response. Innate response and adaptive response. Adaptive response is nothing but acquired or specific immunological response. Now coming to innate response. The innate response occurs immediately on injury or infection. It comprises vascular and cellular elements, and the mediators generated by cells are from plasma or from the plasma. The mediators generated from the cell or from the plasma modify and regulate the magnitude of the response. So utilizing toll and other recognition receptors, sentinel cells in the body tissues such as macrophages, mast cells, dendritic cells, they detect specific pathogen associated molecular patterns, and this triggers the release of cytokines, particularly interleukin-1 and tumor necrosis factor TNF-alpha, as well as various chemokines. First, recognition receptors, they get activated and this triggers the release of cytokines. IL-1 and TNF-alpha, interleukin-1 and TNF-alpha act on local postcapillary venular endothelial cells, causing vasodilation and fluid exudation, expression of adhesion molecules on the cell surfaces, and exudate contains enzyme cascades that generate bradykinin from kinogen and C5a and C3a from complement. Complement activation lyses the bacteria. And C5a and C3a stimulate mast cells to release histamine, which dilates the local arterioles. The tissue damage and cytokine release produces the cytokines release prostaglandins PGI2 and PGE2, which are vasodilators, and leukotriene LTB4, which is a chemotaxis. And these cytokines, they stimulate synthesis of vasodilator nitric oxide, which increases the vascular permeability. And finally, using adhesion molecules, leukocytes roll on, adhere to, and finally migrate through activated vascular endothelium towards the pathogens. Attracted by chemokines, interleukin 8, C5a, and leukotriene B4, where phagocytosis and bacterial killing takes place. This is the overall mechanism of innate response. Now coming to adaptive response. In case of adaptive immunological response boosts the effectiveness of innate response. It has two phases, the induction phase and the effector phase. The effector phase consists of antibody mediated and cell mediated components. During the induction phase, native T cells bearing the CD4 and CD B co-receptors are presented with antigen, triggering proliferation. CDB bearing T cells develop into cytotoxic T cells that can kill virally infected cells, and CD4 bearing T helper cells are stimulated by different cytokines to develop into Th1, Th2, Th17 or Treg cells, T regulatory cells. Th1 cells, they develop into cells that release cytokines that activate macrophages. These cells, along with cytotoxic T cells, control the cell mediated response. And Th2 cells, they control antibody mediated response by stimulating B cells to proliferate, giving rise to antibody secreting plasma cells and memory cells. The Th17 cells are similar to T1 cells and are important in some human diseases such as rheumatoid arthritis. And T regulatory cells restrain the development of immune response. And the effector phase utilizes both antigen and cell mediated responses. Coming both antibody and cell mediated responses. Coming to antibody response. Antibodies provide more selective complement activation, more effective pathogen phagocytosis, more effective attachment to multicellular parasites facilitating their destruction, and direct neutralization of some viruses and other bacterial toxins. Cell-mediated reaction provide CD8 cytotoxic T cells that kill virus-infected cells, cytokine-releasing CD4 T cells that enable macrophages to kill intracellular pathogens such as tuberculous bacillus, and memory cells primed to react rapidly to a known antigen. Help for B cell activation. Inappropriately deployed immune reactions are termed hypersensitivity reactions. Anti-inflammatory and immunosuppressive drugs are used when normally protective inflammatory or immune response escape the control. This occurs mainly in the autoimmune diseases such as rheumatoid arthritis. By this we complete the innate and adaptive response. Now coming to rheumatoid arthritis. Rheumatoid arthritis is one of the commonest chronic inflammatory conditions in developed countries and a common cause of disability. The affected joints become swollen, painful and deformed and immobile. And the disease also has cardiovascular and other systemic manifestations and carries an increased risk of mortality. The degenerative joint changes that are driven by autoimmune reactions are characterized by, in case of rheumatoid arthritis, the degenerative joint changes that are driven by autoimmune reaction are characterized by inflammation, proliferation of synovium, erosion of cartilage and bone. These are the characteristics. And the primary inflammatory cytokines IL-1 and TNF-alpha have major role in the disease. Coming to disease-modifying anti-rheumatoid drugs. The drug therapy for rheumatoid arthritis is of two types, NSAIDs and DMARDs. DMARDs are nothing but disease-modifying anti-rheumatic drugs. NSAIDs, they only relieve the symptoms. Though they are the first line of drugs, they only relieve the symptoms. Whereas disease-modifying rheumatoid arthritis drugs, anti-rheumatic drugs, they halt, that is stop or reverse the disease itself. Now coming to the pharmacological classification of anti-rheumatic drugs, they are categorized into two types, disease-modifying anti-rheumatoid drugs or DMARDs and adjuvant drugs, which are nothing but prednisolone and other glucocorticoids. Coming to disease-modifying anti-rheumatoid drugs, they are categorized into non-biologicals and biological agents. Non-biologicals are again categorized into immunosuppressants. Examples are methotrexate, azathioprine and cyclosporine. Coming to other immunomodulators, examples are sulfasalazine, hydroxychloroquine or chloroquine, both are anti-malarial drugs, and leflunomide and tofacitinib. These are other immunomodulators. Coming to biological agents, they are categorized into TNF-alpha inhibitors and other biologicals. Examples of TNF-alpha inhibitors are etanercept, infliximab and adalimumab. Coming to other biologicals, they are anakinra, abatacept and rituximab. Coming to NSAIDs, NSAIDs are the first line of drugs which afford symptomatic relief in pain, swelling, morning stiffness and immobility, but they do not arrest the disease process. Coming to DMARDs, The disease-modifying antirheumatic drugs are sometimes referred to as second-line drugs, as they are given only when other therapies like NSAIDs fail. But the DMARD therapy may be initiated as soon as a definitive diagnosis has been reached, and their clinical effects are usually slow. That is, they takes months in onset, and it is usually to provide NSAID cover during the induction phase. It is usual to provide an NSAID cover during the induction phase. If the therapy is successful, concomitant use of NSAIDs or glucocorticoids can be reduced. Though the success rate is variable, use of DMARDs in early or mild rheumatoid arthritis should be weighed against their potential adverse effects. Coming to the goals of drug therapy in rheumatoid arthritis, the primary goals are to ameliorate the pain, that is reduce the pain, swelling and joint stiffness, to prevent articular cartilage damage and bony erosions, and to preserve the joint function and prevent deformity. These are the primary goals of drug therapy in rheumatoid arthritis. Now, coming to in DMARDs, the first class of drugs are immunosuppressants. First drug is methotrexate. It is a folic acid antagonist with cytotoxic and immunosuppressant activity. Methotrexate is a folic acid antagonist. This dihydrofolate reductase inhibitor, specifically dihydrofolate reductase inhibitor, and a common first line of choice in rheumatoid arthritis. Beneficial effects are probably related to inhibition of cytokine production, chemotaxis, and cell-mediated immune response. It has more rapid onset of action than other DMARDs, that is 3 to 6 weeks, and oral bioavailability of methotrexate is variable and may be affected by food. Probenecid and aspirin, they increase the methotrexate levels and toxicity, and trimethoprim can add to the inhibition of dihydrofolate reductase and depress the bone marrow. So you should be careful while undergoing this therapy because it has various drug interactions. The first one is probenecid and aspirin, they increase the levels and thereby leading to toxicity. The next is trimethoprim. It can add to the inhibition of dihydrofolate reductase and depress the bone marrow further. Coming to contraindications, methotrexate is contraindicated in pregnancy, breastfeeding, liver disease, active infection, leukopenia, peptic ulcer, and renal disease. The next drug is azathioprine. This purine antimetabolite acts getting converted to 6-mercaptopurine by the enzyme thiopurine methyltransferase TPMT. It is a potent suppressant of cell-mediated immunity, appears to be selectively affect the differentiation and function of T cells and natural killer cells. It also suppresses the inflammation. Given along with corticosteroids, azathioprine, it has steroid-sparing effect for which it is primarily used now, especially in cases with systemic manifestation. It is not combined with methotrexate. Azathioprine is not combined with methotrexate. Other immunosuppressants like cyclosporin, chlorambucil, cyclophosphamide are rarely used in rheumatoid arthritis and are reserved for cases not responding to other DMARDs. Now coming to other immunosuppressants. Previously we have discussed about immunomodulators. Now we will discuss about other immunosuppressants. The first drug is sulfasalazine. It is a combination of sulfapyridine plus 5-amino-salicylic acid. Sulfasalazine is combination of sulfapyridine plus 5-amino-salicylic acid. It has anti-inflammatory activity and is primarily used in ulcerative colitis. Sulfasalazine is used in ulcerative colitis. Sulfapyridine. splits off in the colon by bacterial action and is absorbed systematically, appears to be the active moiety. In ulcerative colitis, 5-ASA, which is nothing but amino salicylic acid, acts locally in the colon and is the active moiety. Generation of superoxide radicals and cytokine elaboration by inflammatory cells may be suppressed with the use of sulfasalazine. Coming to the adverse effects, neutropenia and thrombocytopenia occur in 5 to 10% of the patient. Hepatitis may be possible and it is a second line of drug for milder cases and can be combined with methotrexate. As it causes neutropenia or thrombocytopenia, constant monitoring of blood count is essential. The next drugs are chloroquine and hydroxychloroquine. These are anti-malarial drugs. They have relatively low toxicity, but the efficacy is low and bony lesions are not prevented. Reduce the monocyte interleukin 1 and consequently inhibit the B lymphocytes. By the use of chloroquine and hydroxychloroquine, antigen processing may be interfered and lysosomal stabilization and free radical scavenging are the other proposed mechanisms. And for rheumatoid arthritis, these drugs have to be given for long periods. This leads to accumulation in the tissue, especially melanin containing tissue, resulting in the toxicity, especially retinal damage and corneal opacity. Chloroquine and hydroxychloroquine, whenever used to treat rheumatoid arthritis, they must be given for long periods. This leads to accumulation in melanin containing tissue, resulting in retinal damage and corneal opacity. This is less common and reversible in case of hydroxychloroquine when compared to chloroquine, which is preferred over chloroquine. Coming to other adverse effects are rashes, graying of hair, irritable bowel syndrome, myopathy and neuropathy. Coming to indication, chloroquine or hydroxychloroquine are employed in milder non-erosive disease, especially when one or few joints are involved, or they are combined with methotrexate or sulfasalazine. The next drug is leflunomide. This immunomodulator inhibits the proliferation of activated lymphocytes in patients with active rheumatoid arthritis. It inhibits the proliferation of activated lymphocytes. Arthritic symptoms are suppressed and radiological progression of the disease is retarded. Leflunomide is rapidly converted in the body to an active metabolite which inhibits the dihydroornate dehydrogenase, and pyrimidine synthesis is in actively dividing cells. So, leflunomide is a pyrimidine synthesis inhibitor. Antibody production by B cells may be depressed and the active metabolite has long T-half of 2 weeks. Leflunomide therefore is given as a loading dose of 100 mg daily for 3 days followed by 20 mg once a day. Coming to adverse effects, they are diarrhea, headache, nausea, rashes, loss of hair, thrombocytopenia and leukopenia. Increased chances of chest infection and raised hepatic transaminase levels are seen. Coming to contraindication, it is not used in children and pregnant or lactating women. Leflunomide is an alternative for methotrexate or can be added to it, but the combination is more hepatotoxic. Combination with sulfasalazine improves benefit. Next drug is tofacitinib. It is a new synthetic drug approved for severe cases of rheumatoid arthritis that are not responding to methotrexate. Tofacitinib can be used along or concurrently with methotrexate but should not be combined with azathioprine, cyclosporin or biological DMARDs. It is a JAK3 and JAK1 kinase inhibitor, interferes with JAK-STAT signaling pathway and DNA transcription. Production of inflammatory mediators and release of cytokines is inhibited. Coming to the adverse effects of tofacitinib, They are headache, insomnia, diarrhea, hypertension, anemia, susceptibility to respiratory infection, flaring of tuberculosis and liver damage. Coming to next class, biological response modifiers. In that, the first one is TNF alpha inhibitors. Because TNF alpha plays a key role in the inflammatory cascade of rheumatoid arthritis by activating membrane-bound receptors TNF-R1 and TNF-R2 on the surface of T cells, macrophages, etc. Exogenously administered soluble TNF alpha receptor protein or antibody can neutralize it and interrupt the reaction. This TNF alpha inhibitors mainly suppress the macrophages and T cell function. Inflammatory changes in joint regress and new erosion is slowed. But susceptibility to opportunistic infections, including tuberculosis and pneumocystis pneumonia, is increased because TNF alpha plays important role in combating the bacterial infection, especially granulomatous infections. The first drug is etanercept. It is a recombinant fusion protein of TNF receptor and Fc portion of human Ig1, immunoglobulin G1. It is administered by subcutaneous injection, 50 mg weekly. Coming to adverse effects, pain, redness, itching and swelling occur at the injection site. Chest infections may increase, but the immunogenicity is not a clinical problem. The next drug is infliximab. It is a chimeral monoclonal antibody which binds and neutralizes TNF alpha. 3 to 5 mg per kg is infused intravenously for every 4 to 8 weeks. An acute reaction comprising of fever, chills, urticaria, bronchospasm and rarely anaphylaxis may follow the infusion. Susceptibility to respiratory infections is increased and worsening of congestive heart failure has been noted with infliximab. The next drug is adalimumab. This recombinant monoclonal anti-TNF antibody is administered subcutaneously 40 mg every 2 weeks. Combination of MTX is advised to improve the response and decrease the antibody formation. Adverse effects are injection site reaction and respiratory infections. The other TNF alpha inhibitors are setrolizumab and golimumab. The next is interleukin-1 antagonist. The first drug is anakinra. It is a recombinant human interleukin-1 receptor antagonist. Interleukin-1 receptor antagonist, anakinra. Though clinically less effective than TNF alpha inhibitors, it has been used in the cases who fail on one or more DMATs. The dose is 100 mg subcutaneously daily. Adverse effects are local reaction and chest infections, and several other IL-1 inhibitors like rilonacept and canakinumab have been also introduced. The next drug is abatacept. It is a recombinant fusion protein, combines part of Fc domain of human Ig with extracellular domain of T cells, inhibiting T cell inhibitory receptors CTLA4. By binding to CD80 and CD86 molecules, abatacept, it prevents the second signal for co-stimulation of T cells, and it is indicated for moderate severe active rheumatoid arthritis not responding to methotrexate, and it is not given with TNF alpha antagonists due to greatly increased risk of infections. The next drug is rituximab. Chimerized monoclonal antibody depletes B lymphocytes and is indicated for B cell lymphomas as well as some autoimmune diseases. It is combined with methotrexate for treating active rheumatoid arthritis not responding to methotrexate plus TNF alpha inhibitor. Now finally coming to corticosteroids. They have potent immunosuppressant and anti-inflammatory activity. Can be inducted almost at any stage of rheumatoid arthritis along with first or second line drugs. If potent anti-inflammatory action is required while continuing the NSAID plus DMARD. Symptomatic relief is prompt, but they do not arrest the rheumatic process. Though joint destruction may be slowed and bony erosions are delayed. And long-term use of corticosteroids carries serious disadvantages. Therefore, either low doses, that is 5 to 10 mg prednisolone or equivalent, are used to supplement NSAIDs. And once used in this manner, it is difficult to withdraw steroids. Exacerbation is precipitated, patient may become steroid dependent, or high doses are employed over short periods in cases with severe systemic manifestation, that is organ-threatening disease and vasculitis, while the patient awaits response from a remission-inducing drug. In cases with single or few joint involvements with severe symptoms, intra-articular injection of soluble glucocorticoid affords relief for several weeks. Joint damage may be slowed. However, this procedure should not be reported before 4 to 6 months. These are some of the points regarding the corticosteroids. Long-term use often carries serious disadvantages. In cases of single or few joint involvements, intra-articular injection can be given and it can afford relief for several weeks. But this should not be repeated before 4 to 6 months. Thank you for watching. Please subscribe for further videos on pharmacology and other related pharmaceutical sciences.